Bismillahirrahmanirrahim. Let's start the physiology of endocrine system from first aid. In this video, we will discuss the different hormones released by the hypothalamus and the pituitary gland, including the anterior pituitary and the posterior pituitary. Then we will individually discuss the growth hormone, the antidiuretic hormone, and prolactin. So let us start with introduction to all these hormones. These hormones are basically not organized in this page. They are in a haphazard manner. So first, let me arrange them for you. So we have two main glands, the hypothalamus and the pituitary gland. The pituitary gland is further divided into the anterior pituitary and the posterior pituitary. Now I have represented anterior pituitary with red color and the posterior pituitary with blue color. The posterior pituitary have two secretions. First is the ADH, which is written right over here, and the second is oxytocin. I don't know why oxytocin is so down. It must be second, but anyways, ADH is written over here and oxytocin is written over here. So these two are the secretions of posterior pituitary. Then let us have a look on the secretions of the anterior pituitary. So the secretion of anterior pituitary is melanocyte stimulating hormone, ACTH, the prolactin, the TSH, the growth hormone. All these are secretions of anterior pituitary. And then the hypothalamus have different releasing hormones, such hormones which are controlling the secretions of anterior pituitary, such as the corticotrophin releasing hormone controlling ACTH, dopamine controlling TSH and prolactin, growth hormone releasing hormone controlling the growth hormone, gonadotropin releasing hormone controlling the FSH and LH. And so these are the secretions of hypothalamus. Now we can discuss them. First, let's have a look on ADH. ADH is also called as vasopressin. The complete name is antidiuretic hormone. Now the name is very simple. Diuresis means the formation of urine. When you say the patient is taking diuretics, it means that the patient is taking such drugs which increase the urine output. So antidiuretic means that the urine output will be decreased, which means that the water will be reabsorbed from the kidneys. So increased water permeability of distal convoluted tubule and collecting ducts in the kidney increase the water reabsorption. So this will definitely decrease the osmolarity of blood, since you know the solute quantity will be more or less same and water will increase, and at the same time the osmolarity of urine is going to increase because the solute are kind of same and we have decreased the water. So more concentrated urine will be produced when there will be increased ADH. Another point is that in alcohol consumption there is decreased ADH. So ADH, which was supposed to decrease the urine output, which was supposed to reabsorb water, is inhibited by alcohol consumption. So somebody who has taken alcohol, he will have increased urination, and so he will feel dehydration. He will have to drink more water and will urinate more. The second hormone released by posterior pituitary gland is oxytocin. So let us discuss oxytocin now. Oxytocin is a very interesting hormone. It is also called as the love hormone because this hormone basically modulates fear, anxiety, social bonding, mood, depression. Oxytocin is released when a person hugs somebody or when a female, interacts with the male. At these situations, oxytocin is released. So it's a very interesting hormone called as the love hormone, but function wise it has two main functions. First is the uterine contractions during labor, so it is very necessary for the delivery of a baby at the end of pregnancy. And second, it is responsible for milk let down reflex. So when the baby suckles the nipples, that suckling action leads to the release of oxytocin. So you see, it's the love hormone. So these were the two secretions of posterior pituitary. Now let us have a look on the releasing hormones released by the hypothalamus. Corticotrophin releasing hormone, it basically stimulates MSH, ACTH, and beta endorphin. These hormones are released by the pituitary gland. So most of the glands of hypothalamus are promoting the secretions of pituitary gland. Only dopamine is a secretion of hypothalamus which inhibits prolactin and TSH produced by the pituitary gland. So now, most of the hypothalamic releasing hormones stimulate the secretions of anterior pituitary. Only dopamine inhibits. All right. The corticotrophin releasing hormone stimulates ACTH and MSH. Corticotrophin releasing hormone is decreased when a patient is using chronic glucocorticoid, and that is very simple to understand. Glucocorticoids are basically, cortisol. They are similar to cortisol. When there will be increased cortisol, definitely cortisol will inhibit corticotrophin releasing hormone so that there is less ACTH and less stimulation of cortisol, since ACTH is responsible for release of cortisol. So if a patient is taking glucocorticoids, which mean kind of cortisol, so there will be inhibition of corticotrophin releasing hormone. Now this was very simple. Second secretion is dopamine. I already discussed it since it is a very unique one. It is the only secretion of hypothalamus which is inhibiting a secretion from the anterior pituitary. So it mainly inhibits prolactin and it also inhibits TSH, thyroid stimulating hormone. Since it inhibits prolactin, it is also called as prolactin inhibiting factor. Now this is very simple to understand that dopamine antagonist, of course, if dopamine is inhibiting prolactin, so dopamine antagonist will increase prolactin, and increased prolactin will cause galacturia, since prolactin increases the formation of milk in the breast. Then growth hormone releasing hormone, this stimulates the release of growth hormone, and if we take analog of growth hormone releasing hormone, that will definitely increase the production of growth hormone. That is very simple to understand. Then gonadotropin releasing hormone, this stimulates the release of gonadotropins inside the pituitary gland, and it is very easy to understand that hyperprolactinemia inhibits gonadotropin releasing hormone. Now let me tell you, prolactin is stimulated by estrogens and other sex hormones. Prolactin is stimulated by sex hormones, but prolactin inhibits gonadotropin releasing hormone, which then inhibits FSH and LH, which then inhibits the sex hormones, the estrogen, the testosterone, and so on. So this is a very interesting kind of interaction. At this point, what they are saying is hyperprolactinemia will suppress gonadotropin releasing hormone. All right, gonadotropin releasing hormone analog, such as leuprolide, it suppresses hypothalamic pituitary gonadotropin. Definitely, when there is an analog, so you are already giving gonadotropin releasing hormone. So via negative feedback, it will inhibit the formation of gonadotropin releasing hormone. An interesting point is that pulsatile release of gonadotropin releasing hormone is effective. Continuous release is not effective. Pulsatile release will increase FSH and LH, and it will lead to puberty and fertility and these things. So if we have to increase the fertility of a person, we inject gonadotropin releasing hormone in pulses. So we basically attach a machine which inject a certain amount of gonadotropin releasing hormone after 90 minutes or after some time. Because continuous gonadotropin releasing hormone will have decreased effect, or in fact a vice versa effect. So this is a very interesting thing. Pulsatile secretions is not a very unique phenomena. Gonadotropin releasing hormone is effective when it is released in a pulsatile fashion. Similarly, parathyroid hormone PTH, which is released by parathyroid gland, that is also effective when it is released in a pulsatile fashion, and it is not effective if it is released continuous. In fact, it has the opposite effect when it is released continuously. And similarly, the pituitary gland also have such naughty secretion, and that naughty secretion of pituitary gland is growth hormone. So growth hormone is also supposed to be released in a pulsatile fashion. So you see several glands have a naughty hormone. The hypothalamus have a naughty hormone, gonadotropin releasing hormone, which is only effective when it is released in a pulsatile fashion. The anterior pituitary have a naughty hormone, growth hormone, which is released in a pulsatile fashion. And the parathyroid gland also have a naughty secretion called as the parathyroid hormone. All right, then we have the MSH, the melanocyte stimulating hormone, that will increase the pigmentation of skin. You can see hyperpigmentation in Cushing disease, but that is due to a different mechanism. Basically, the adrenocorticotrophic releasing hormone, the ACTH and the MSH, they both have a same precursor, and that precursor is pro-opium melanocortin. So in Cushing disease, when there is increased ACTH, as a result, we do have increased MSH, and this increased MSH leads to hyperpigmentation. So we have hyperpigmentation in Cushing's disease, right? Then we have the oxytocin, which we have already discussed. Now let's have a look on the prolactin. I already told you that it increased the formation of milk, and prolactin is inhibited by gonadotropin releasing hormone. So we have discussed these points. Now somatostatin, yes, somatostatin is basically an anti-secretory hormone, you can say. It is produced in the hypothalamus, and it inhibits the secretion of growth hormone and thyroid stimulating hormone. So it is also called as growth hormone inhibiting hormone. And then last but not the least is the thyroid releasing hormone. Just like other releasing hormones, this also stimulates the formation of thyroid stimulating hormone, another hypothalamic hormone which is stimulating the secretion of anterior pituitary hormone. An interesting point is discussed in this diagram below, and that point is, I've already mentioned that dopamine inhibits prolactin, and we have already discussed thyroid releasing hormone promotes TSH. But TSH and prolactin are like siblings. So dopamine not only inhibits prolactin, it also inhibits the TSH. And similarly, thyroid releasing hormone not only stimulates TSH, but it also stimulates the prolactin. But the major regulatory factor of prolactin will be dopamine anyways, and the major releasing factor for thyroid stimulating hormone will be thyroid releasing hormone, but they do have an effect on each other. Let me tell an anatomical point over here. The cells inside the pituitary gland do have particular names according to their secretions. So the cells which are producing thyroid stimulating hormone are called as the thyrotrophs. Similarly, the cells which are producing the growth hormone are called as the somatotrophs. And so the list continues. The cells which are producing FSH and LH are called as the gonadotrophs. The cells which are producing the ACTH are called as the corticotrophs, and the cells which are producing prolactin are called as lactotrophs. You must know about this. They may test this in any kind of MCQ. This information is kind of something which a person thinks that is not important, but in an MCQ you may have options saying that which cell is secreting more hormones, and you may have options gonadotrophs, corticotrophs, lactotrophs, and some names are really obvious, like gonadotrophs, gonad I mean sex-related hormones, very simple. But somatotrophs, you see, somatotrophs for growth hormone. This is something which you have to memorize. So somatotrophs for growth hormone. Anyways, this is not a big deal for you. Now let's head towards the extra information which I have mentioned over here. And that extra information says, first of all, let me tell you about sarcoidosis. Now, sarcoidosis is a pathology, although we will discuss it in other systems also. So I'm giving you a brief overview. We have the activation of vitamin D in the liver and then the kidney. In the kidney, it is hydroxylized into 125 dihydroxy vitamin D. Now, what happens in sarcoidosis is an autoimmune disorder in which this activation of vitamin D also occurs in macrophages, which result in increased activation of vitamin D. Now, this increased activation of vitamin D will lead to hypercalcemia, since vitamin D increases the serum calcium. And now hypercalcemia can lead to granulomas inside different locations. Now, if you have such a granuloma in the pituitary stalk, now you know the pituitary stalk was responsible for bringing hormones from the hypothalamus towards the anterior or the posterior pituitary. Now, if there is a blockage in this pituitary stalk, what will be the effect on secretions of anterior pituitary? Almost all the secretions of anterior pituitary will be decreased because all the secretions were stimulated by hypothalamus, corticotrophic releasing hormone, growth hormone releasing hormone, gonadotropin releasing hormone. Only prolactin was being inhibited by this hypothalamus with the help of dopamine. So when there is a blockage in the stalk, the prolactin secretion is elevated and all other secretions of anterior pituitary are inhibited. So this was the point which I have discussed over here in this point. All right. Now, I don't know why this is gone so blur. Let me maybe correct this if I can. I think I cannot. Yes, I can. All right. The second point is leptin. Leptin is released by the adipose cells. Leptin stimulates gonadotropin releasing hormone. So a certain amount of fat is beneficial for you, is required for you because the leptin will stimulate the gonadotropin releasing hormone, and definitely gonadotropin releasing hormone leads to the stimulation of LH and FSH, which will have different sex effects in your body. Now, what happens is we get a scenario of a girl who is going for modeling contest, or she is an athlete, or she is very conscious about her weight. So, a girl which has very less fat in her body. As a result, there will be no leptin and no gonadotropin releasing hormone. So, you will have a scenario with a girl having amenorrhea and she is very much conscious about her weight. So the cause will be some kind of issue in the hypothalamus because there is decreased leptin, right? So this was an extra point. Now, once we have the brief overview of all these hormones, let us discuss three hormones individually. First hormone is the growth hormone, which is also called as the somatotropin. I have already discussed it is called as somatotropin. One very important point about growth hormone is that most of the effects of growth hormone are modulated or they happen with the help of insulin like growth factor. This insulin like growth factor, which is released from liver. So, primarily, growth hormone acts on the liver, and then the insulin like growth factor released by this liver produces the different effects, which we call as the effects of growth hormone. Definitely, we say that the growth of bones, the growth of muscles, it is a function of growth hormone. But this function is really, really modulated by the insulin-like growth factor, insulin-like growth factor 1, which is also called as somatomedin C. All right. Another point about growth hormone is that it increases insulin resistance. So as insulin tries to decrease glucose, growth hormone increases glucose. Kids have to grow and kids like sweet. So growth hormone increases the sweet of your blood, right? So it's just to make it easy for you to memorize. Growth hormone have insulin resistance. It is diabetogenic. And as I told you, this is the naughty hormone of pituitary gland, which means it is released in a pulsatile fashion. And it is only effective if it is released in a pulsatile fashion. The growth hormone is a very important hormone. You must be wondering that how can I increase growth hormone or how can children increase growth hormone in them to have a good height? So what factors increase growth hormone? Exercise and the increased duration of sleep, hypoglycemia. So if you want children to grow more, ask them to play more games and then have a long sleep. Just ignore the studies and that's it. They are going to have a good height. On the contrary, the growth hormone is inhibited by obesity, hyperglycemia, and definitely aging also decreases the formation of growth hormone since you do not require that much of growth hormone as you progress in age. And then we have somatostatin and somatomedin. These are the regulatory molecules which inhibit growth hormone. So we have studied three factors which increase the growth hormone. In fact, four factors, including the puberty. And then we have several factors which decrease the growth hormone. What if there is excess growth hormone? Now, the effect of excess growth hormone really depends on age. If the patient is in growing age, so excess growth hormone will lead to increased growth. This will be called as gigantism. The child will have a great height, like a giant. But if the increased growth hormone occurs after the growing age, for instance, a person of age 30 having increased growth hormone, now the height is not going to increase. In this condition, there will be symptoms such as, enlarged hands, enlarged feet, enlarged facial features, and these kind of things, such bizarre symptoms. And this is called as acromegaly. So increased growth hormone in adults leads to acromegaly, but in children it leads to gigantism. And if there is decreased secretion of growth hormone during the growing age, the child will have a decreased height or a decreased size. That is called as dwarfism. Two of the names are very easy to memorize: gigantism, a giant child, and dwarfism, dwarf, small one. And the treatment is pretty simple. You give somatostatin analogs. Since there is increased growth hormone, and we know that somatostatin inhibits the secretion of growth hormone, so we give somatostatin analogs such as octreotide, which decreases the growth hormone secretion. Now, if I have a look on the diagram, so you must basically think conceptually. Growth hormone must lead to growth of different things. It will uh, lead to more amino acid uptake so that there can be more protein synthesis, more DNA and RNA synthesis, more collagen, more amino acid uptake, more protein synthesis in the muscle as well, and all kind of factors which lead to increased growth are modulated by the growth hormone. Then we have the antidiuretic hormone. I have already discussed that it is called as vasopressin. It is synthesized in the hypothalamus and it is stored and secreted by the posterior pituitary. We have discussed it that it is produced in the hypothalamus and then it travels with the help of neurophycins, and the axons which releases the growth hormone are present in the posterior pituitary. So it is basically secreted in the posterior pituitary but synthesized in the hypothalamus. Now the function is, since it reabsorbs water, so it regulates the blood pressure. Reabsorption of water will increase the blood pressure and it will decrease the serum osmolality. So we say via V1 receptors, it regulates the blood pressure, and via V2 receptors, it regulates the serum osmolality. But the primary function is to regulate the serum osmolality. And so the primary regulator for release of ADH is also the plasma osmolality. You can see it is a primary regulator for ADH release. It basically increases the absorption of water by increasing the aquaporin channels in principal cells of renal collecting ducts. Now, just as insulin, we have two types of diabetes. First is in which there is impaired production of insulin, and that is called as type 1 diabetes. And the second form is where there is formation of insulin, but that insulin is not effective. We call it as insulin resistance. That is called as type 2 diabetes. Now we have a similar case over here. If there is decreased formation of ADH, that is called as central diabetes insipidus. What is diabetes insipidus? Decreased effect of ADH is called as diabetes insipidus. Just like decreased effect of insulin is called as diabetes mellitus, right? So decreased effect of ADH is called as diabetes insipidus. If this decreased effect is due to decreased formation of ADH, it will be called as central diabetes insipidus, since there is a central issue, an issue in the CNS. And if there is enough ADH, but it is not effective, the kidneys are not responding to it, it will be called as nephrogenic diabetes insipidus. And since the kidneys are not responding, the brain will increase the release of ADH. So there may be increased or normal ADH in nephrogenic diabetes insipidus. All right. We do have an ADH analog called as desmopressin. So if we have central diabetes insipidus, which means if we have decreased ADH formation, so we have a simple solution, we can give desmopressin. This was all about the ADH. Now let's have a look on prolactin. Prolactin simply increases the formation of milk in the breast, and you know that prolactin is inhibited by dopamine. The most unique point regarding prolactin is that it is inhibited by the dopamine, and it is basically released by the anterior pituitary. Let me tell you another thing. If you get a scenario in which they tell you that the pituitary gland is increased in size, you know what, whenever pituitary gland is increased in size, so since it is placed at a very special point, pituitary gland is placed in sella turcica and we have the optic chiasm around it. So enlargement of pituitary gland leads to suppression of optic chiasm, and that is why we have bitemporal visual field defects. So they will tell you these kind of symptoms. There's bitemporal visual field defects, or there is headache, and these kind of things. If they do not tell you any kind of symptom regarding the hormone, I mean, now you do know that there is an increased size of pituitary, but is there increased formation of growth hormone, or increased formation of FSH or LH, or increased formation of, thyroid stimulating hormone? If they give you no kind of lead, so most probably it will be increased formation of prolactin, right? So the most common cause of increased size of this pituitary gland is increased formation of prolactin, or you call it as the prolactinoma. And what prolactin does is, it inhibits the gonadotropin releasing hormone, which will inhibit the formation of FSH, LH, and the sex hormones. So increased prolactin will decrease libido. It will cause to amenorrhea. It will cause to, you know, decreased spermatogenesis, decreased ovulation in female, and these kind of effects. Now, what regulates prolactin? You do know that dopamine inhibits prolactin, and thyroid releasing hormone stimulates prolactin. So that is a pretty simple mechanism. Now, dopamine agonist. Of course, if dopamine inhibits prolactin, so dopamine agonist will also inhibit prolactin, and dopamine antagonist will promote prolactin. So that is a very simple concept. There's nothing difficult in this. Now let's have a look on this diagram also. So you can see that insulin is being inhibited by dopamine, and it is being promoted by thyroid releasing hormone. But the dominant effect is of dopamine. So if there is nothing coming from the hypothalamus, overall there will be increase in prolactin, because the dominant effect was that hypothalamus was inhibiting prolactin via dopamine. All right. Now, once the prolactin is produced, this prolactin inhibits gonadotropin releasing hormone, which inhibits the sex hormones, and it promotes the formation of milk production. Now, just see how thankless is this prolactin. Although estrogens are increasing the formation of prolactin, but still the prolactin is so thankless, so rude, that it inhibits gonadotropin releasing hormone, which will ultimately lead to less estrogen. All right. In renal failure, there is increased prolactin because the elimination of prolactin is reduced in renal failure. So this was all about prolactin. These are not very high yield points. The main importance will be when we will discuss the pathology. Thank you very much. I hope you enjoyed the video. We will discuss the next parts in the next videos.